Today, we are going to take a deep dive into the issue of healthcare. It's Labor Day, and one of the primary issues that is intertwined with labor and working in the United States is healthcare, and that's a problem. I've been an advocate for a long time of actually severing that tie, and this would be not only good economically, not only would it be good for both workers and companies economically to separate healthcare and health insurance from jobs, but it would also be really good psychologically. It would be really good morally and ethically, quite frankly, for people to be able to pursue interests and jobs on the basis of what they actually care about and find rewarding, rather than having to make decisions about sticking it out in a job that you hate. Because if you leave the job, you will lose health insurance that could be still, quite frankly, mediocre, but better than the alternative or cheaper than the alternative. So we're going to actually start today with growing our understanding of where the United States healthcare system is ranked, first of all, because unless we understand what we have now accurately, it's going to be hard to figure out the direction that we should go in. We will then look at the impact of Obamacare over the last several years, something that we've talked about before. I will also tell a story of my $829 10-minute specialist's visit, which still has not been resolved, by the way. And then we're going to get into debunking some of the really bad arguments against changing the healthcare system for something more like every single other rich Western developed country has, whether it's Canada or Germany or the UK or many others that we've talked about. And then we will ultimately circle back to how do we pay for this stuff? And we will talk to Gerald Friedman, Jerry Friedman, from my undergraduate alma mater, the University of Massachusetts, about what would this actually cost? What would doing something like what Bernie Sanders wants to do cost? And what you will notice when we go back to the way that we have covered healthcare over the years is that the themes and the substance have stayed quite similar over the years, but the language used has become language that understands that these ideas, the ideas of Bernie Sanders and other leftists in the United States around healthcare, have become significantly mainstreamed, where the language used to be sort of apologetic. We used to have to understand that these were at least considered radical far left ideas, which have been extraordinarily mainstream, particularly over the last 3 years. Dating back really to Bernie Sanders' presidential candidacy, Democratic presidential candidacy in the 2016 Democratic primary. So the substance is much the same. The analyses have not drastically changed, but there's definitely a different tone in terms of the political will and the interpretation of a lot of this stuff. So let's get right into it. A deep dive today into the American healthcare system.
The David Pakman Show at davidpakman.com.
The right likes to say national healthcare systems are bad, bad, bad. Canada's terrible. The UK is a disaster. It's all bad. All in defense of this immoral, for-profit, employer-connected healthcare system that we have in the United States. The DC think tank known as the Commonwealth Fund did a study of the healthcare systems of 11 wealthy countries, and it found, maybe a surprise to some of you, maybe not, that the American system is the worst by multiple measures. And this includes countries like the UK, Australia, Canada, Germany, Sweden. The UK's National Health Services was the best in many categories. The 5 categories evaluated were access to care, equality of access for people of different incomes, administrative efficiency, how well the care process works, and how good the health outcomes are. Now, it's not all a panacea for these other countries, right? So, like, for example, the UK system was first overall, but was 10th in terms of healthcare outcomes. But the big consistency was that the US did terribly in every single area. Access to care, the US was a disaster. For example, 44% of low-income people in the United States have trouble accessing care, compared to only 7% of low-income people in the UK. And notably, the report says that there's been some improvement as a result of Obamacare, but this is more evidence that Obamacare is no incredible, wonderful upending of the healthcare status quo. It's a slight improvement, or it has slowed down the worsening of some areas of the system, but it's no massive victory. And in total, in overall performance, the US was dead last. The leaders were, as I mentioned, the UK was first, followed by Australia and the Netherlands. Where did the US turn up at the top of the list of countries? Well, in terms of how much we spend, we are leading the way. And this relates to many, many issues. This relates to the fact that we have a system that seeks profit. We've got a total bureaucratic inefficiency due to the medical billing and insurance system that we have. It's a total train wreck. We spend more than every other country on the list, and we have the worst overall healthcare system. How can anyone be proud of that?
You know, right-wingers go on and on about how America is number one. I don't think we're number one in this category. I guess number 11 here.
This should be a point of national pride, right? I mean, to the right-wing patriots, wouldn't it be nice to be able to be really proud of how well our healthcare system works, instead of like how many bombs we have or something like that? Or does that point of view make me a beta male? I don't know. Maybe it does, that I think it would be nice to be proud of our healthcare system.
It seems like you want more people to survive in this country.
How
and
dare
for
I?
people to live longer and get over diseases.
That's such a sissy perspective to have. And no country is perfect. Some will point out that, waiting times for some procedures are longer in some of the countries on the list. Others might point out that costs might be lower in other countries because maybe nurses aren't paid well or something like that. There are always problems, but this study pretty nicely sums up sort of like the net impact of all aspects of the system. And it's just absolutely vile and disgusting. And I want to remind you, I've said this before, there is something called HR 676 out there. HR 676 is a House proposal called the Expanded and Improved Medicare-for-all Act. And it basically is single-payer healthcare, not in a literal sense. What it actually would do is take the Medicare system we have, which has done a better job of holding costs not as high. Lower might be a bit of a stretch, but from going as high, it's a system that works quite well in many ways. The idea would be to expand Medicare to everybody. This has been proposed a number of times by House Democrats. It basically never has a shot at going anywhere, but it is there. It is there, and a lot of people don't know about it, and you can go to whoismyrepresentative.com, figure out who does represent you in both the Senate and the House. Start making calls, send faxes, do whatever you want.
I mean, it seems like whenever we talk about overhauling the healthcare system, you're going to have legislation that's hundreds of pages long. You know, it's not going to be this simple, but you're effectively just making the age requirement for Medicare 0. And that's a lot easier to do than to maybe pass Obamacare or the American Health Care Act.
All you're doing is going into Medicare, and this is a slight oversimplification, but changing the minimum age at which you can get Medicare. It is a very interesting proposal that is completely dead in the water, unfortunately. But still, HR 676, just talk about it. Call your representatives about it. Let's talk about Obamacare, the Affordable Care Act. The last few days have seen a number of very, very apoplectic and out of control headlines saying, shocking, Obamacare premiums up 22%, 25% in some cases. And yes, it is true that under the Obamacare Affordable Care Act law, premiums for those plans will be up an average of 22% next year. There are many consumers who will be down to basically just one plan option through the Obamacare exchanges. And this is not just opposition reporting. The administration itself has indeed confirmed this. But the misinformation from so much of the alarmist, out of control reporting on this is so extensive that I want to dig into it with you here at the top of the show. There are a whole bunch of different pieces of information that are missing from these reports. People see a report saying Obamacare premiums up 22%. Number one, that ignores the subsidies on those plans. So while you will have an average, and this is based on the silver level plans, there's bronze, silver, gold, and platinum level plans that sort of establish generally how much of one's health insurance expenditures are covered by insurance. Silver is the sort of benchmark that is used. 22% increase in Obamacare silver level plans. However, most of that increase for many Obamacare recipients is going to be covered by subsidies. So you see the headline, and it makes for a really great headline, but it's not actually telling us, well, how much more are the individuals actually going to be paying? And of course, this ignores altogether that this has nothing to do at all with individuals who have insurance through their parents, insurance through their employer, insurance through their school, etc. So really, really interesting headline. Republicans are going absolutely nuts about this. We've heard the term death spiral be used many, many times, that Obamacare is just going to basically self-destruct and implode. But it is super, super important to understand that this refers to a small percentage of all the people in the country. And it also is not accounting for the fact that many of these increases are going to be covered. Additionally, let's not forget that we've been seeing increases to premiums for a very, very long time. And even without the Affordable Care Act, we would be seeing increases to premiums. Would they be higher or lower than with the Affordable Care Act? Well, it's hard to say. Remember that even without the Affordable Care Act, even without an insurance mandate, uninsured people are still going to go to the emergency room, use it as primary care, and those who have insurance are going to subsidize that. That is a cost, part of which is eliminated by mandating insurance the way we see through the Affordable Care Act. So there's a whole bunch of stuff here, guys, which is not in the headlines, and it completely upends what the story here really is.
Yeah, we don't really have a control here to see how higher the premiums would have gone up without Obamacare.
No doubt.
From 1999 to 2009, according to the Kaiser Institute, premiums for families nearly doubled.
Right.
And the Republican response to all this is just to blow the whole thing up, to repeal it and kick 20 million people off their coverage.
No doubt.
Yeah, and insurance subsidies cap premiums at a percentage of families' income, so many Americans won't end up paying more. And another issue here is that this number also hides a lot of local variation that people are unaware of.
This is not a perfect system, right? I don't think Pat thinks Obamacare is perfect. I don't think Rachel thinks Obamacare is perfect. I've been clear that Obamacare is not perfect, right? It does some good things. The banning of outrageous price increases or rejection of coverage for pre-existing conditions is a really good thing. Allowing people under age 26 to stay on their parents' insurance until age 26 is a really good thing. Reducing, or I guess it's really the opposite, growing the pool of people who have insurance that are paying something in is a good thing. And of course, covering millions of additional people is a really good thing. But the system at its core is so corrupt and so immoral and so unethical. That is really the basic issue for me. And the Republicans who complain about the 22% increase to silver level Obamacare plans, not accounting for premiums and the fact that most people aren't even on these plans at all, ignores that the entire for-profit system we have is the problem. And if you turned it over to Republicans, they're not going to fix that. They're going to say we need more competition. We need to allow insurers to say, oh, you have a pre-existing condition, you're out, etc. Their views would only make this problem worse.
And we know what the most popular and cost-effective healthcare programs are around the world.
Yeah.
It's single payer. That's what works well in Britain and all over Europe, all over the world. And instead, we in America have a long tradition of getting healthcare coverage through our employers.
Yeah.
But really, it's not the best way to go.
And Rachel, think about all of the ways in which the costs are obviously going to be high. You have middlemen earning profits in our healthcare system all over the place. You have bureaucracy and complexity. You have the entire medical billing apparatus. In many cases, preventative medicine is ignored, which we know over the long term increases costs. You're paying for the uninsured anyway. We have this current situation of the aging baby boomer population combined with an obesity crisis that we can't possibly separate from the factory food epidemic and sedentary lifestyles. Of course, it's going to be expensive.
Yeah, it's really difficult also for the families who make too much to qualify for subsidies. They will find themselves in a pinch. And I'm equally worried for people with chronic illnesses that have to switch plans that might have been getting a good price for a drug that they're receiving for treatment. And then when they switch, that cost can go up.
And it's super easy to hear what Rachel is saying and say, well, it's Obama's fault. These are systemic issues that are inherent to the type of arrangement we have in this country with regard to health insurance. I've been saying it all week. Hillary Clinton being the next president will not solve this in any way. I want to be super clear about that. But it will at least allow us a 9th, 10th, 11th, and 12th year of Democratic presidents to try to take the Affordable Care Act and expand it and move it further to the left. Go ahead.
Do people also completely just disregard the fact that since Obamacare was enacted, a lot more people have health insurance?
Of course.
That just...
that's ignored. Nobody's going to talk about that.
Good.
We might as well ignore it too, because if you either get it or you're going to ignore it, right? I mean, it doesn't even make it. It really is bewildering.
The David Pakman Show at davidpakman.com. The David Pakman Show at davidpakman.com.
Okay, I have an anecdote for you. That's really all it is, but it's an interesting one in a sense about the failures of our healthcare system, although I know that this is both, number one, relatively minor in the grand scheme of things, and that I'm fortunate enough to be in a position not to be crippled financially by what I'm about to tell you, and it's also not a serious health issue, okay? So here's my medical background on this particular story. Years and years ago, I was having knee pain when I would run and when I would bike and when I would play basketball. And my doctor said, it seems like it's more than just, you're not 19 anymore. You should go and see a podiatrist and see what's going on. It could be related to your feet. So like 10 years ago or something, I went to a podiatrist and the podiatrist said, yep, your knees and ankles are not correctly aligned. We need to correct your arches with some orthotic insoles. She made me the insoles. Obviously, in the United States, the insoles themselves were not covered by insurance. So I bought the insoles and paid my copay for the podiatrist. And I've had those insoles for a year. And over time, for many years, over time, the insoles start to flatten out just from the weight of the person wearing them. And I was starting to have knee pain again. So I wanted to go to a podiatrist, get a new evaluation, find out if I need new insoles. And also have them look at my feet. I have something called Greek feet, hilariously, where the second toe is longer than the big toe, and it can sometimes scrunch that second toe and create some weird stuff on the front of the foot and the nail. So I wanted that looked at as well. Okay, so I made an appointment with my podiatrist. I did all of the right things. I have insurance. The insurance is a totally normal, middle of the road, what's called a silver plan, meaning that my specialist copays are $40. This is with a big insurer here in Massachusetts called Tufts Health Plan. I don't know if people around the country know about Tufts Health Plan. It's a pretty big insurer here. So I do all the right things. I call my insurance. I say, does my plan cover podiatry? David, yes, it does. Great. Which podiatrists does my insurance cover? Here's a list. Great. Do I need a referral from my regular doctor to see a podiatrist? No, you don't. You just call the podiatrist and make an appointment. Fantastic. Do I need pre-authorization from you, my insurance, in order to have the visit covered? No, you don't, David. You just go. If it's someone on our list, we will cover all but the copay. Perfect. I make the appointment. I go. The doctor sees me for 10 minutes, okay? 10 minutes. Says, David, your arches are flat, so you need new insoles. We don't make insoles here. Here's a prescription for how the insole should be made. Go to this other place. The insurance is not going to cover the insoles. The insoles are going to be $375. But your toes look fine. Nothing to worry about there with your Greek feet. Perfect. I take my prescription. I pay my $40 copay, and I'm on my way. 2 weeks go by, and I get a bill for $414 from the podiatrist. Now, how could this be? I paid my $40 copay. I didn't need pre-authorization. I didn't need a referral. Podiatry's covered. I went to a podiatrist covered by my plan. Well, it turns out that podiatry is covered, and I didn't need a referral, and I didn't need pre-authorization, but the diagnosis of flat feet is not covered, and that is how I was diagnosed. and therefore I owe $454 for the visit minus the $40 copay, or $414. So I say, wait, hold on a second. I went in for knee pain. How should I know in advance what the diagnosis is going to be? My insurance says that's simply not our problem. So anyway, I was able to speak to someone who said, what you should do is call the doctor and ask if this is definitely, wink, wink, the right diagnosis. Now, of course, someone at Tufts Health Plan can't say, David, let me help you commit insurance fraud. Call the doctor and ask for a different diagnosis so that we will cover it. Obviously, they can't do that. But I'm reading between the lines and they say, this is the system we have. I would call the doctor's office and explain the situation. So I call the doctor's office and I explain, and they say, oh, we're going to get someone to talk to the doctor. Maybe the doctor can rebill this some other way, maybe focusing on the Greek feet part or some other diagnosis other than flat feet. So at this point, again, fortunately, this is more a curiosity for me. Can I ultimately get this covered? I may well end up paying $375 for the insoles, $414 for the visit, plus my $40 copay, right? That's $829. In addition to my monthly insurance premium of $425 a month to get insoles, okay? In other countries, insoles are $100 and the podiatrist themselves makes them, and it would be a fraction of the cost. So understand that part of the inefficiency here is look at the number of people that are involved with this 10-minute specialist visit. I spoke to one insurance person before making the visit appointment to figure out what is and what isn't covered. I spoke to another insurance person after. I saw the doctor. I was then checked out at the office by someone in the billing department to pay for my copay. I then called and spoke to someone in the finance office for the podiatrist, who then will go back and speak to the doctor and the care supervisor. We're up to six people being spoken to in 7 different interactions, and they may end up rebilling this some other way. How much of the gap between the $100 this would have cost in other countries, maybe $150, to the $829 that in total I'm going to pay, how much of that nearly $700 difference is related to the fact that I spoke to 6 different people about billing related issues? And again, I'm lucky that this isn't serious and that I can afford it. If I end up having no choice but to pay $829 total for this ridiculous fiasco, I'll be okay. That's not the case for a lot of people who can't afford an unexpected $400 expense. And then, of course, there's the broader question of why would a 10-minute visit to a podiatrist even be priced at $454, which is again related to all of this BS that is part of the system: inefficiencies, bureaucracy, billing, coding, non-payment from people who don't have insurance and ultimately are just going to skip out on the bill. It is truly a perverse system, and I don't want to make my story seem any more important than it is. I tell it merely as an anecdote that I have. Send me your thoughts. If you have a similar story, please post it in the comments for the YouTube video for this segment. I do want to hear from you about it. Kentucky Senator and ophthalmologist Rand Paul is known as one of the more kind of strictly libertarian members of the U.S. Senate. And one of his, I call it one of his greatest hits in terms of just saying wacky things, was when he said that single-payer healthcare is effectively slavery, that it makes doctors slaves, that it makes nurses slaves. Everybody's a slave when you have single-payer healthcare. And we've now learned he's going to be going to healthcare slavery headquarters, Canada, for a hernia operation. You can't write this stuff. So I want to take this piece by piece with you. Let me set it up first. Here's Rand Paul with his now infamous claim that single-payer healthcare is a form of slavery.
Thank you very much. With regard to the idea of whether or not you have a right to a health care, you have to realize what that implies. It's not an abstraction. I'm a physician. That means you have a right to come to my house and conscript me. It means you believe in slavery. It means that you're going to enslave not only me, but the janitor at my hospital, the person who cleans my office, the assistants who work in my office, the nurses. If you have a right to their services, basically once you imply a belief in a right to someone's services, do you have a right to plumbing?
So there it is. Everyone is a slave in a single-payer healthcare system, according to Rand Paul. If you have single-payer healthcare, everybody involved in the system is condemned to a lifetime of slavery. And I'm assuming that when he says that, when he makes that critique, he believes slavery is bad, so that he wouldn't want to be participating in such a system, except that Senator Rand Paul is now opting to go to Canada for hernia surgery. Remember that incident that took place where Rand Paul was, I guess, raking leaves on his front lawn, and a neighbor who I believe was an anesthesiologist tackled him. And Rand Paul ended up with 6 broken ribs and a bruised lung. And apparently this hernia resulted from the incident as well, or from the recovery from the incident. So we have this market system, which I guess he believes is great in the United States. Socialized medicine is bad. Canadians are being put on horrible waiting lists for non-emergency procedures. But it turns out that Shouldice, I'm not exactly sure how it's pronounced, Hernia Hospital in Ontario is a really good place to have hernia repair done. And that's where Rand Paul is going to go. Now, I'm going to anticipate already what the defenders of Rand Paul are going to say. They will write in and say, David, hold on. I am opposed to the socialized medicine system like Rand Paul, but this particular hospital that Rand Paul is going to is a private hospital, not a public hospital. That is true by the letter, but most of the money of this clinic comes from the government. They accept the socialized healthcare plan. They're doing just fine. No slaves, no problems. One of the best places in the world to have hernia repair done. And it's a perfectly reasonable model. You don't need to have the government be the healthcare provider and the employer of the doctors and the employer of the nurses. You still can have private hospitals, but you have one payer, which is the government, which provides a system of non-profit health insurance, period. Just because the provider is private, as is the case here, understand that it's mostly a publicly funded provider. And that's a model that's very popular in the single payer world. And what we have in the end is Rand Paul choosing, because of the quality of care at a mostly publicly funded health clinic in healthcare slavery hub, Canada, he is taking his taxpayer salary out of the United States and to a different country. And I was thinking, Pat, on the one hand, there's this kind of hypocrisy or double standard. In another sense, this is sort of libertarianism as intended by them. He's rich and powerful, so he can go to Canada and get better care. Other people can't even afford the flight to Canada, never mind paying for the care as a non-citizen. So they end up with the care that happens to be available to them with their terrible health insurance in the part of the country where they happen to live. It's both an incredible double standard, but a version of libertarianism that a lot of people like Rand Paul actually support.
I really just can't get over how dumb the argument is that if you are for single-payer healthcare, you're for slavery. Like, doctors are compensated a good deal of money. They make 6-figure salaries. They don't have to be in that position if they don't want to. They're free to go. You can't say the same thing about slaves. And if you're going to make the slavery argument when it comes to universal healthcare, you have to make it when it comes to any public official. Like Rand Paul, as a politician, he's a slave too, apparently.
We will see what other follow-up there is from Rand Paul here, and it'll probably just kind of fade away like many of these stories do. It's just our elected officials being hypocritical. That sadly is not actually news.
The David Pakman Show at davidpakman.com. Welcome back to the David Pakman Show.
It's great to welcome back to the program Gerald Friedman, professor of economics at my undergraduate alma mater of the University of Massachusetts. Jerry, we've spoken before about your detailed analyses of the costs and benefits to a Medicare-for-all or other single-payer type healthcare system in the United States. We now have Bernie Sanders's 2017 Medicare-for-all proposal. So what better time than now to actually talk about what such a system would cost? Now, you see the detractors of these systems say, big tax increase, incredibly expensive. It's more promising of free stuff that's not really free. The counter to that would be that it would save much more money than it would cost. So top line, how do we start thinking about those numbers?
Okay, well, the first thing to do is to think about there are actually 3 different numbers The first number is what a Medicare for all system would do for the entire U.S. economy versus what we have now. Because, of course, there are big numbers involved. What we have now are big numbers. 18% of our gross domestic product, 18 cents of every dollar that we produce in this country goes for healthcare now. Our Medicare for all system would lower that. We would be able to get the same healthcare for less money. And this is a point on which I think there is almost no disagreement. Critics will admit that, yeah, it would save money on the current healthcare system. It's almost impossible to argue otherwise because Medicare is a more efficient bill payer than the current insurance systems, private health insurance. Medicare doesn't involve the type of marketing or profits that are involved in the current system. Medicare saves money for providers because it's easier for providers to bill a single system than to bill the dozens of insurance companies and hundreds of insurance plans in an average American state. To give you just one quick, easy example to show this, in Toronto General Hospital in Ontario, Canada, with a single payer system, there are 2 people who do billing in that hospital. Massachusetts General Hospital is about the same size, the same number of beds, more or less, same number of patients. There are 450 people who do billing there. I mean, so you go and save money.
Yeah. Now, what about there's an argument that part of the savings would be because if you have a single payer, they could force providers to just have to charge less, and thus it would significantly depress wages within the medical infrastructure for doctors and nurses. How do you respond to that?
Well, not particularly for doctors and nurses. Now, they would pay providers less because providers would have lower costs because of this the saving on the billing process. And there are some providers who currently are earning what economists call rents, which is a situation where you have a monopoly and you exploit everybody else. The biggest rents are in the pharmaceutical sector. You have this hepatitis C pill that sells a course of treatments costs $85,000 in the United States. It costs, no joke, $200 in India. So they are exploiting the rest of us. And the research for that, as for most drugs, is paid for in the first place by the National Institutes of Health and the National Science Foundation. So we already paid for this drug, and then we're paying again. So in my estimates for Medicare for all, you'd be saving large sums on bargaining effectively for drugs. And there are also some elite hospitals that would be facing cuts, but not that much. Medicare currently pays hospitals about 22% less than what hospitals get from private insurance companies. That's overall. Now, that is about my estimate. It's a little more than but it's close to my estimate of the administrative savings from single payer. So, yeah, so the hospitals, some hospitals like Mass General would probably get a bit less because they are currently exploiting the rest of us to some extent. There's abundant evidence on this. But overall, hospitals would be a wash, doctors would be a wash. Doctors would actually benefit. Those doctors who currently treat Medicaid patients would get a raise. So overall, we would achieve savings of maybe $600 billion or so on our total healthcare spending. And those savings would largely come from being more efficient, doing the same stuff better.
So along those lines, there was an analysis done of the proposal that Bernie Sanders had during the campaign, right? So this is not the most recent proposal, but from the one during his campaign. And it estimated that the cost to people who are earning salaries, wage earners, would be about a 2.2% surcharge, which I estimated on someone earning $50,000 would be about $1,200 or $1,300 roughly. Can you talk a little bit about, in the analyses you've run, sort of what would be the costs to different parties?
Okay, well, there we get to the second and third questions. The first question is the total economy. The second question is the federal government. And yes, there would be a tax increase. That 2.2% was actually what Bernie was proposing last year, plus some payroll tax. There would be the federal government would be spending more and taxing more, but that would be replacing what we're already spending on taxes that go to private bodies. When we buy health insurance, it's mandated by the government. We have to buy health insurance, and we have to pay for health insurance premiums. To me and to the Supreme Court, that means it's a tax. It's just a tax collected by private agencies. Now, the third question is for the individuals. Who would be paying more, who would be paying less? Because overall, we'll be paying less in public taxes to the government than in private taxes to health insurance companies, because the whole system will be more efficient. But there'll also be particular savings for some people, because in Bernie's proposal and in the proposals that I've written, we have an element of an income tax, or a tax related to how much money you have and how much you can afford to pay. Whereas now your health insurance premium is either a lump sum, everybody pays the same, or sick people or people in families with a sick family member pay more. So we put a tax on sickness, which is a double tax in effect, because if you're sick or you have a family member who's sick, your earning capacity goes down because you're spending time taking care of your family member, or that family member can't have a job because they have a disability, whatever. And then on top of that, you have to pay this extra health insurance because the health insurance figures out that you're sick, and they get you into a plan that covers sick people. I mean, they have to sell you insurance, and they can't charge you extra for pre-existing conditions, but they work it.
Well, that relates to this idea of everybody with pre-existing conditions under Trump Care versions 1, 2, and 3.0, all of which so far have failed, would have access to a plan regardless of pre-existing conditions. But that's very different than it being affordable, and it sounds like that's sort of what you're getting at.
Yes, what we already have is something in that direction, but there are real limits on it. Whereas what they were proposing, access, I would use a word that you can't put on television or commercial television or radio. But access just means they have to offer you a plan. But they could offer it at $80,000, $150,000. I mean, and okay, you have access. You can buy it if you could afford it, and who could afford that?
And so you and I have been talking about a single payer system. And are you experiencing that there are people who are confused, understandably so, not as a criticism, between a single payer system, where the government would be the one payer, versus nationalizing healthcare, where the government runs and operates the hospitals and employs the doctors and nurses? Do you see as much confusion about that as I'm seeing?
Oh, yes, absolutely. There's and that confusion is promoted by critics who say we're going to have a government takeover of health insurance. No, we're going to have a government provision of health insurance for people. If you want to buy health insurance on your own, this isn't in Bernie's plan, but it's in a lot of the plans that I envision, then yeah, you could buy health insurance. Why somebody would do that, I don't know, because they would already be getting it through the government for free, in effect, because they'd already be paying the taxes. But there would not be a government takeover of the provision of health care. Britain has that.
Right.
And arguably, the healthcare system in the United Kingdom is the best in the world. Government provision of healthcare through the National Health Service is extraordinarily efficient and delivers very good care. But we're not talking about that. We're talking about something like Canada, where they have private provision of healthcare. Doctors work independently, hospitals are run independently, but there is government finance. So all the bills go to a government agency. If you go to a doctor in Canada, billing amounts to the following. You swipe a card through their machine. The doctor or the nurse types in the diagnostic code and the treatment code, and you're done. That's it. The government agency will send a check for your services to the doctor. The doctor deposits that check in her private bank account. All done. That's it.
Jerry, what is the best place for people to be able to check out your detailed proposals of how this would all work financially and economically?
Well, one place would be Physicians for National Health Plan, pnhp.org. My 2013 financing proposal is up there. And there's a wealth of good information there, top quality research on the Canadian healthcare system, foreign healthcare systems, issues in the United States healthcare system. There's some of my work is up there, and there's a lot of work by other excellent scholars. Also, another very good place for healthcare in general is the Kaiser Family Foundation, kff.org. And finally, the Commonwealth Fund.org. My most recent published work on single payer was from 2015 for New York. And that is, if you Google New York Health Plan, I don't remember the website.
Fair enough.
Yeah.
All right.
Also, you can always write to me at
Absolutely.
UMass.
Yes. And people, I'm sure, will find how to do that. We've been speaking with UMass Professor of Economics, Gerald Friedman. Always great to talk to you.
Absolutely. Thank you for having me.
The David Pakman Show at davidpakman.com. The David Pakman Show at davidpakman.com.
Hey, David, won't Medicare for all kill jobs? This is a really loaded question, and I'm glad to have the opportunity to talk about it. There's this imagery of killing jobs that is a very political imagery, to be quite honest with you, because the reality is that all the time, governments, federal government, state governments, departments of the government, whoever, all the time decisions are being made that have an economic impact and they have an employment impact. Sometimes we're talking about thousands. We're talking about 1,000 new jobs, but we lose 200, but there's some economic gain or some social gain from that change. So number one, we've got to get away from this imagery of, quote, killing jobs, because all the time as a country evolves, decisions are made that create jobs and that eliminate jobs. They cause firings, they cause layoffs, they create new industries, etc. What we have to understand is that a lot of those jobs that exist in the medical field right now, which would be unnecessary and thus would disappear under a Medicare for all system, are not jobs that are actually providing for the greater good. What I mean by that is, if you consider medical health insurance fraud investigators, medical billing and coding experts on the insurance side, medical billing and coding experts on the hospital side. By the way, not all of them would go away under single payer. Under many single payer systems, they remain. All of this bureaucracy plus the profit that is implicit in the system, that doesn't lead to better health outcomes. It doesn't lead to lower costs. It's simply, yes, providing work to the people that are in those jobs. And it is work that is being paid for at the expense of people who are availing themselves of healthcare services. So would some of those things be eliminated if Medicare for all were to be passed? Yeah, some of them would. The economy would have to adjust. In history, this has happened many, many times. I give this example often, and I think it applies here. Think back to the development of the automobile. The automobile was a much more efficient means of transportation than horse and buggy carriages or whatever you call them. There were people who said this is going to eliminate the jobs of the drivers, I don't know what they were called, of the horse buggies. Would that be a reasonable reason not to allow cars to be developed or to prevent the development of automobiles? Of course not. Ultimately, those individuals no longer were in demand in that role of horse buggy drivers. They were reintegrated into the workplace in other ways. Some of them probably suffered long-term unemployment. That's true. But we need to stop falling for this idea that any policy that will result in any job loss is unacceptable. In fact, it's actually a very sort of center-right idea. I mean, there's this infamous video of Milton Friedman arguing with some college kid where the college kid says, shouldn't there have been consequences for some car company that had a car that was dangerous? And Milton Friedman said, okay, well, hold on. So there was a negative consequence from the car, from some kind of negligence. How much should that car company have paid to fix that problem? If the car costs 10 grand and it cost them 10 grand to fix their problem, should they have been forced to do it? What about, should they have paid $100,000 to fix a problem on a $10,000 car? At a certain point, you get to this realization that there are going to be negative consequences to doing the right thing. And whether you're on the Milton Friedman side of that or not, it doesn't actually matter. The point is, every single day, decisions are being made, policy is being affected, where some jobs are lost, there is some economic cost. It has to be accepted. In a country of 340 million people, anytime you make any kind of change, there will be people who gain and people who lose. Right now, the losers are people who can't afford to pay for care, people who get substandard care, people who are going bankrupt because of medical bills. And those who gain are the for-profit insurance companies, the elected officials that perpetuate the status quo in exchange for donations and whatever else. Yes, some jobs won't be necessary under Medicare for all. The net benefit is gigantic, and that or some system like it is still the right thing, even though there will be jobs that will no longer be necessary. And we just have to accept that and not fall for the right-wing talking point that it will kill jobs. And by the way, that is an on the defensive talking point. When the right goes to Medicare for all will kill jobs, they've often already conceded some of the benefits of just such a system in terms of access to care and in reducing cost. That's why they retreat to it. And it is a very, very weak counterpoint to some kind of nonprofit system, the likes of which many countries have already employed. Let me know what you think. We have a great bonus show for you today. Become a member or a patron to get instant access at www.joinpakman.com or at patreon.com/David Pakman Show. Let's go to the phones at 617-830-4750, starting today with our caller from the 917 area code. Who's calling today from 917?
Hey, David, is this me?
That is you indeed. Who is this?
I'm Milo.
Milo,
And,
what's going on?
Just to be, so my question is about Medicare for all. So, a really common right-wing and quite frankly, a talking point also from like a lot of centrist Democrats is that, Medicare for all really only works in countries with like smaller populations. Like when I bring up that it works in like Sweden or Norway or Finland or other Nordic countries, they say like, oh, well, those countries have like relatively smaller populations, but in a country like America with like 320 million plus people, it can't work.
Yeah.
So I'm just wondering, like, how do you rebut that point?
Well, first of all, with 90% of the people who say that, you just say, why not? Why would more people make it not work? And usually, so that'll get rid of 90%. 90% won't have an answer. The other 10% will have some answer. And then typically, the best thing is not to rebut it with some concocted talking point, but just to tell the truth, which is the way that insurance works. The larger the risk pool, the more predictable the spending is going to be per person, and that actually having more people in the risk pool makes the system more financially viable, that you have way more people who are paying into the system, and that it will actually make healthcare spending significantly more predictable, and that there's simply no reason to say that it only works in smaller countries. I mean, it's mathematically untrue, and it's logically untrue.
Right, yeah. And also, just like sort of one other quick question I had. One of, and I think Kyle Kalinske also brought up this point recently, which is that one sort of, I guess, solution to that worry, or another way we could sort of do it in America is you sort of federally mandate that each individual state implement it, like on the state level,
Sure.
so that population is no longer a worry.
I love that. I've actually mentioned this before. This is a really good point. If you want to make a states' rights sort of positive version of Medicare for all, you actually have each state. You could argue that states, for geographical reasons or because some states have these like cancer alley factories, have higher rates of certain conditions, you can actually say that different states may actually need slightly different financial characteristics, and that each state could implement their own single payer system, partially subsidized by the federal government through the sort of taxation that Bernie Sanders, for example, has proposed. That's a fantastic idea.
Right. All right. Well, yeah, thanks for answering my question, David.
All right. Appreciate the call. Thank you. Very, very important stuff. Great to hear from you.
The David Pakman Show at davidpakman.com.